Alcohol is a very, very sensitive topic. Some people love it, some people hate it. Sometimes it may lead to certain complications, but it's not just with alcohol. Even just other infectious things like hepatitis viruses can lead someone into liver cirrhosis or chronic liver disease. Each of these patients are predisposed to certain complications, one of which includes hepatic encephalopathy. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we'll look at a very important topic, hepatic encephalopathy. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab a piece of paper and let's go. So we'll begin with our warm-up question. I think I forgot to add those to my previous videos. I was doing them in a hurry. So this is a true or false question. Hepatic encephalopathy in cirrhosis is typically precipitated by infection, hypokalemia, abdominal surgery, gastrointestinal bleeding, lactulose therapy. So you may pause the video at this moment, write down your answers. I will give you the answers at the end of the video. So what is hepatic encephalopathy? We can also refer to it as portosystemic encephalopathy or hepatic coma. These three terms are interchangeable, but it is better, and I encourage you to actually use the term portosystemic encephalopathy. So this is just pretty much a spectrum where you get these neuropsychiatric abnormalities in patients that have liver dysfunction after you have excluded all other brain diseases. So it's going to be characterized by changes in personality, intellectual impairment, and a depression in the level of consciousness. And remember, for this condition to happen, there must be a prerequisite syndrome where there's going to be diversion of the blood past the portal blood past the liver into the system via these portosystemic collateral vessels. And remember that hepatic encephalopathy can also occur in patients that do not have liver cirrhosis, either through them developing spontaneous portosystemic shunts or them having a surgically created portosystemic shunt. So it's not only just limited to patients that have hepatic or liver cirrhosis. The bulk majority of patients actually do have liver cirrhosis and end-stage liver disease. So how do we classify this? So there is a nomenclature that has been proposed to describe encephalopathy. We divide it into three main types: type A, type B, and type C. So with type A, this is pretty much hepatic encephalopathy that is associated with acute liver failure. So you can remember A for acute liver failure. Then B is hepatic encephalopathy that's going to be associated with portosystemic bypass. And there is no intrinsic hepatocellular disease, so B for bypass. Then C is going to be associated with hepatic encephalopathy that is going to be associated with cirrhosis, C for cirrhosis, and you also have portal hypertension or portosystemic shunts. This type can be subclassified as episodic, persistent, and even minimal. Alternatively, we can classify hepatic encephalopathy as an acute hepatic encephalopathy, which usually occurs in a setting of a fulminant hepatitis. So you get these decrease in level of consciousness, deterioration that is happening within 2 weeks. Cerebral edema actually has a major role to play in this type of acute hepatic encephalopathy, and most of the times, most of the patients do die. Then you have a chronic hepatic encephalopathy, which occurs in chronic liver disease, and it's often reversible. So remember that with hepatic encephalopathy, it's going to be occurring with portal hypertension patients, either due to spontaneous shunting or those that have surgery where you have anastomosis that are connecting the portal vein and the vena cava, or a transjugular intrahepatic portal caval shunt, or the TIPS procedure. And remember that encephalopathy is potentially reversible. You should identify whatever has been causing the encephalopathy and address it. Some of these neuropsychiatric changes are going to be happening in the setting of liver disease, and they're going to be constituting hepatic encephalopathy until proven otherwise. What are some of the precipitants? Remember that this will be in the background of a chronic liver disease. So you get these acute episodes of encephalopathy, which are going to be precipitated by various reversible causes. These can be classified as metabolic stresses, including infections, including spontaneous bacterial peritonitis, which is a complication of chronic liver disease, alkalosis, azotemia, hypoxemia, or hypoxia, hypoglycemia, fluid and electrolyte imbalances, mainly due to diuretic therapy, so things like hypovolemia, dehydration, and hypokalemia. So whenever you're reviewing a patient that has hepatic encephalopathy, make sure that this patient is not being over-diuresed, because if they are having diuretic therapy, that could have been the reason why they were tipped into a hepatic encephalopathy. Then you may have conditions that increase the gut protein, like GIT bleeding, a high-protein diet, though current studies have shown that there is no role of protein restriction, because most of the patients that we actually receive with hepatic encephalopathy are already malnourished, so they already have a protein deficiency, a protein energy malnutrition. Then you may have constipation or ileus, paracentesis, drugs such as CNS depressants like narcotics, benzodiazepines, anticholinergics. So this means that all patients with hepatic encephalopathy must not be sedated. Alcohol, analgesics. You may also have portosystemic shunt operations like the transjugular intrahepatic portocaval shunts. You may have any other surgical procedures, progressive liver disease, development of hepatocellular carcinoma, non-compliance to hepatic encephalopathy treatment. All these can precipitate a hepatic encephalopathy. Now remember that the mechanism of how this actually develops is largely unknown. Many theories have been postulated, and one of the theories that has been well studied and well known and is actually quite accepted among the scientific community is what's known as the ammonia theory. So remember that the hepatocellular dysfunction and the portosystemic shunt is pretty much going to be leading to inadequate removal of nitrogenous compounds and toxins ingested or produced by the GIT. And these are going to be gaining access to the brain and causing hepatic encephalopathy. So many things have been postulated, like ammonia, short-chain fatty acids, mercaptans, which are going to be causing the fetal hepaticus, or the breath of death in chronic liver patients. You may also have accumulations of false neurotransmitters like octopine, or activation of GABA systems like gamma-aminobutyric acid inhibitory neurotransmitters, as well as increase in blood levels of aromatic amino acids like tyrosine and phenylalaphrine, as well as reduction in branched amino acids like valine, leucine, and isoleucine. Now, let's talk a little bit about the ammonia theory. I won't go into details about the other different types of theories, because this is the one that I would want you to know. So remember that ammonia is going to be of a major role. And I want you to differentiate between two things. So there is ammonia and there is ammonium. So let me just get a pen here so that I can write these things as we go. So we have NH3. NH3 is what we refer to as ammonia. So this is ammonia. So remember that ammonia can easily cross past the cell membrane. It is going to be lipid soluble. Then you have another type of compound that's known as ammonium, which gains a hydrogen ion and it gets a charge. So ammonia cannot cross the lipid layer because it's charged. So I want you to remember this thing, because when it comes to the management of hepatic encephalopathy, and when we use drugs like lactose or lactulose, we're going to be increasing the pH inside the gut such that ammonia will be converted to ammonium and it's not going to be absorbed from the gut. So these are the two chemicals that you really need to take note of: ammonia, which is this one on the first, and ammonium, which is the second one over here. So remember that this is going to be interfering with the astrocytes, the astrocyte neuron interface. And remember that the astrocytes are going to be accounting for about a third of the cortical volume, and they're going to be playing a very important role in regulation of the blood-brain barrier. They're going to be involved in maintenance of things like electrolyte homeostasis, as well as providing nutrients and neurotransmitters, precursors to the neurons. So remember that these astrocytes are also going to be playing a very key role in detoxification of a number of chemicals, including ammonia. So what happens is that in the gut, you have bacteria that are pretty much going to be degrading amines, they're going to be degrading amino acids, they're going to be degrading urea, and they're going to be producing ammonia, NH3. So ammonia can easily be passing through the lipid layers into the bloodstream, and it accumulates into the bloodstream. Ideally, under normal circumstances, the enterocytes also convert the glutamine to glutamate and ammonia by activity of an enzyme that's known as glutaminase. There is also some metabolism that happens in the kidneys to aid in the excretion of ammonia, but most of it is happening in the liver, where ammonia is going to be detoxified by the liver by converting it into urea. Remember that ammonia is going to be consumed by the conversion of glutamate to glutamine, which is a reaction that's largely dependent on an enzyme that's known as glutamine synthetase. Now, in a patient that has a hepatic encephalopathy, remember that number one, you already have a decrease in the functioning of the hepatocytes, or there's a shunt that is bypassing the liver and carrying the blood that's containing the ammonia into the system. So you have the functioning of the hepatocytes being largely reduced, and you have, of course, shunting of the ammonia past the liver directly into the systemic circulation. Now, this ammonia is going to be absorbed by the astrocytes in the brain and is going to be converted to glutamine. Glutamine is going to increase the intracellular osmotic pressure. It pulls water and it causes electrolyte imbalances in the brain, and this is largely going to be causing swelling and cerebral edema, which may lead to increase in intracranial pressure and potentially the brain herniating. Remember that ammonia is going to be produced by the intestinal bacteria breaking down proteins, breaking down amino acids, amines, as well as urea. So what are some of the clinical features that are going to be associated with this? So remember that the symptoms do not become apparent until the brain function is moderately impaired. So acutely present patients are going to present with drowsiness and comatose. They may also have what is known as constructional apraxia, which is inability of them to reproduce simple designs like a 5-point star diagram, and this happens actually very early. Chronically, there may be a disorder in personality, mood, intellect, and even a reversal in the normal sleep rhythm. I will give you a grading of hepatic encephalopathy that I want you to know, especially for when you're reviewing the patients and for the purposes of the exam. So remember that these changes may fluctuate, and the history should be obtained of this fluctuation in the symptoms. Then the patients may be irritable, confused, disoriented. They may have slurred speech. They may also have features of nausea, vomiting, weakness. You may have coma, which occurs with encephalopathy and becomes much, much more marked. And you also may have things like hyperreflexia, increase in tone, which may be features of an upper motor neuron lesions. Convulsions are actually quite rare in hepatic encephalopathy. If you see this, then you should look for other causes. Signs are going to be including the fetal hepaticus, which is the breath of death, a musty, sweet breath odor, which occurs regardless of the stage of encephalopathy. You may have what is known as asterexis, which is the coarse flapping tremors of the hand. When you ask the patient to outstretch their hand, then of course you dorsiflex the wrist. Then you see that their hand is going to be flapping. You may also have constructional apraxia, like I said, a decrease in mental function that can be assessed by using the serial 7s tests. Then you may get neurologic deficits, which is usually symmetric. And remember that the neurologic signs in coma usually reflect bilateral diffuse hemispheric dysfunction. Signs of brainstem dysfunction actually do develop in advanced coma, and they often are going to be during hours and days before the patient actually dies. And remember that the manifestation largely depends on the grade. And this is the grading. So you can have 5 different stages. Stage 0, which is subclinical. Some literature are not going to give you this. Stage 1, 2, 3, and 4. So stage 0, they are asymptomatic. They don't have any loss of cognitive ability. They do not have any neuromuscular dysfunction. Stage 1, they have pretty much mild mental state alterations. So they may have apathy, depression, anxiety, restlessness, irritability. They may have sleep disturbances. They may have a reversal of the sleep rhythm. They may have a slowed intellect. They may have impaired concentration, impaired computing ability. They may have impaired handwriting, so a poor handwriting, but some patients just generally have a poor handwriting, constructional apraxia, tremors, and a monotone voice. Then in stage 2, they may have disorientation, drowsiness, lethargy, poor short-term memory, asterexis, which is an important thing, disinhibited behavior, ataxia, dysarthria, automatisms like yawning, blinking, and sucking. Then stage 3, they may be stuporous, but still arousable. They may have excessive sleep, which is somnolence. You may have confusion, amnesia. They may have anger. This is supposed to be anger, not ager. They may have paranoia or bizarre behavior and features of upper motor neuron signs like hyperreflexia and extensor plantar responses, increase in tone. You may also have muscle rigidity and nystagmus. Then stage 4, you may have coma. You may have dilated pupils, oculocephalic or vestibular oculovestibular reflexes. You may also have a decerebrate positioning. Then how do you make a diagnosis? Diagnosis is largely clinical. Routine liver biochemistry are merely going to be confirming the presence of liver disease, and they're not going to be confirming the presence of encephalopathy. You may sometimes get an EEG, an electroencephalogram, but when you do, it's going to show you this diffuse slow wave activity. Even in the mild cases, it's actually quite sensitive, but it's not specific for early encephalopathy. Other investigations are going to be excluding any treatable disorders or treatable causes, but you generally want to get the levels of ammonia, blood urea nitrogenous waste, urea, electrolytes, creatinine, AST, ALT, ALP, GGT, serum bilirubin, serum albumin, a hepatitis profile, RPR, an HIV test, an abdominal ultrasound, a full blood count, ESR or C-reactive protein, serum glucose, alpha-fetoprotein, and a CT brain to, of course, rule out the possibility of any intracranial lesion or intracranial hemorrhage. You may also alternatively get an MRI. You also want to do a cerebrospinal fluid examination, but this is not routinely needed for most patients. But the only thing that you may get from a CSF study is an increase in the level of the protein. And conditions that may present similar to hepatic encephalopathy and have to be ruled out include things like infections, subdural hematomas, hypoglycemia, and intoxication. Now, how do we manage? The first and foremost thing is want to identify and remove the possible precipitating cause. So drugs like cerebrodepressants should be removed. Constipation should be addressed. Electrolyte imbalances due to overdiuresis should be addressed. General measures: if a patient is unconscious, push in an NGT. Make sure that you check their blood glucose because they may be hypoglycemic. You generally want to give them dextrose to prevent hypoglycemia because hypoglycemia is a trigger. Then for patients that are at grade 3 or grade 4, you generally want to manage them in the ICU, and you may want to also perform prophylactic endotracheal intubation, especially for patients with severe encephalopathy. So one aim of treatment is to reduce and eliminate the substrates for the generation of nitrogenous compounds. So we want to maintain the nutrition with adequate calories, and this, if necessary, can be given through a fine bore nasogastric tube. We do not restrict the proteins for more than 48 hours. So long ago, we used to actually restrict the dietary proteins, but this is no longer necessary, and it's actually much more detrimental to cirrhotic patients because these patients are often malnourished and they may actually even exacerbate a protein energy malnutrition. Then we want to cleanse the bowel with an enema in patients with gastrointestinal hemorrhage, or more often give them oral lactulose syrup, which can be given also through an NG tube. So we give purgatives and enemas to empty the bowel of the nitrogenous substances. So we give either oral or via NG tube or rectally administered lactulose. Remember, the adverse effects of this include dehydration and hypokalemia. Then lactulose can be given at a dose of 30 to 45 mils 3 times a day as an osmotic purgative that is going to be reducing the colonic pH. Remember that once you reduce the pH, it means that you have a lot of hydrogen ions, and this can bind to ammonia and convert it into ammonium. And ammonium is not going to be absorbed because it's positively charged. That's how one of the mechanisms as to how lactulose actually works. So the dose actually should be adjusted such that you produce 2 to 3 soft stools per day. Then lactulose may be administered as an enema in patients who are comatose and who are unable to take the medication orally. The recommended dose is 300 mils of lactulose plus 700 mils of water administered as a retention enema 4 hours as needed. Lactulose, which is a beta-galactoside sorbitol, 30 grams daily can be given, and this is going to be metabolized by the colonic bacteria and is comparable in efficacy to lactulose. Of course, lactulose is what we have routinely in our setting. Then lactose can also be given in patients who are deficient for lactase. And remember that lactulose, lactulo, and lactose are all going to be fermented by the bacteria to organic acids to reduce the pH and increase the hydrogen ions such that ammonia remains trapped in the gut. And this actually prevents it from diffusing across the gut wall, and this is going to be excreted. That's one mechanism. The second mechanism is that it has a laxative effect, which increases the excretion of ammonia from the gut. Then we want to reduce the colonic bacteria load that produce ammonia, so we give antibiotics. So rifaximin is the main unabsorbed and well-tolerated long-term antibiotic that we're going to be using. It generally prevents further episodes of hepatic encephalopathy. remember that there are two drugs that you can give, rifaximin as well as neomycin. We generally want to use neomycin as a second line, and we want to avoid it as giving it, especially for long-term periods, because remember, it's an aminoglycoside, and this can precipitate side effects like ototoxicity and nephrotoxicity. Although there has been no evidence that treatments like lactulose or rifaximin are actually going to be helping someone who has encephalopathy, which is caused by an acute liver failure, but we often reserve these for patients that have encephalopathy in the background of chronic liver disease or liver cirrhosis. So rifaximin can be given at 400 milligrams orally 3 times a day. Neomycin can be given at 250 milligrams orally twice a day, or even as much as 4 times a day. The doses can even be as high as 4,000 milligrams per day. And remember that neomycin is going to be given as a second line after initiation of treatment with lactulose. Then metronidazole is given in our setup, 400 milligrams orally 3 times a day, or by NGT, or 500 milligrams IV 3 times a day. It's also effective in acute situation. And remember, one of these adverse effects is neuropathy. It may also cause some gastric discomfort. Then, of course, you should stop or reduce the diuretic therapy. Then treat any infections that are present with broad-spectrum antibiotics. Just make sure that they're not nephrotoxic and make sure that they're also not hepatotoxic. Zinc can also be given because patients that have cirrhosis often tend to have a zinc deficiency, so you can give it as zinc sulfate. And even in patients that do not have a deficiency, it actually does improve the levels of ammonia. It reduces the level of ammonia in the blood because it's going to be increasing the activity of ornithine transcarbamylase, which is an enzyme that is involved in the urea cycle. Then, of course, this is going to increase the ureagenesis, resulting in the loss of ammonia ions. Then, of course, you're going to be giving intravenous fluids as necessary. Do not give too much sodium. Sedation actually deepens the encephalopathy, and you should generally avoid it. For patients that are in coma that is caused by fulminant hepatitis, meticulous support as well as nursing care with prevention and treatment of complications actually is going to increase the survival rates. Hemodialysis can also help in clearing out the ammonia, especially those that have acute liver failure. High-dose corticosteroids, exchange transfusion, as well as other complex procedures designed to remove circulating toxins generally do not improve the outcome. Then patients deteriorating because of the fulminant hepatic failure can be saved by a liver transplant. There has been some time where they advocated for levodopa, bromocriptine, flumazenil, sodium benzoate, infusion of branched amino acids, keto analogs of essential amino acids, prostaglandins, but those have been proved not to be effective. Then, of course, complex plasma filtering systems like an artificial liver that have been designed are still under research and require much more studies, but they do show some promising results. Prognosis largely depends on the underlying cause. In chronic liver disease, correction of the precipitating causes usually reverses the encephalopathy and they regress without any permanent neurologic sequelae. Then in some patients, especially those with portal-cavo shunts or transjugular intrahepatic portal system shunting, they do require continuous therapy, and irreversible extrapyramidal signs or spastic paralysis rarely develop. Patients that have coma or stage 4 encephalopathy associated with fulminant hepatitis is usually fatal. Up to 80% of the patients die despite intensive therapy, and the combination of advanced chronic liver failure and portal systemic encephalopathy is often fatal and is often the death sentence. So hepatic encephalopathy and cirrhosis is typically precipitated by infections, true. Hypokalemia, true. Abdominal surgery, true. Gastrointestinal bleeding, true. Lactulose therapy. This can actually precipitate hepatic encephalopathy, as you have seen much earlier. Just rewind the video and go through. You will see the point where I mentioned about lactulose and it actually being able to precipitate hepatic encephalopathy. Thank you for spending your time to listen to this video on hepatic encephalopathy. If you enjoyed, drop a like, drop a comment. To Zambia and beyond. See you in the next video. Until next time, bye-bye.